Salam alaikum. Today's lecture is about brachial plexus injury. Till now, in various different kinds of lectures, you have seen injury to the brain and what will be the problems, then injury to the bones, then what will be the problems, then injury to the muscles like muscular dystrophy, Duchenne's muscular dystrophy, spinal muscular atrophy, then how will be the problems. Now today we are going to see if there is injury to the peripheral nervous system, then how will be the problems. So the brachial plexus is I'm going to explain in detail about brachial plexus. Since we are dealing with the pediatric variety of brachial plexus injury, it is called as obstetric brachial plexus injury. This usually occurs during a difficult vaginal delivery. The traction on the newborn shoulder during the delivery of the head in a breech delivery can injure the cervical roots or fracture the clavicle or the humerus or sublux the shoulder and injure the brachial plexus. So you can see in the mother's womb, the child is head down position. During the delivery, the head will be coming out first. So the most commonly the shoulder will get stuck with the pubic symphysis of the mother, and if you give it traction, that is going to cause injury to the brachial plexus. So this is the normal brachial plexus anatomy. This the brachial plexus is formed from majorly C5, C6, C7, C8, T1 nerve roots. So these nerve roots together forms some roots, divisions, trunks, and later on they are further divided into the major upper extremity nervous system, that is ulnar nerve, median nerve, radial nerve, musculocutaneous nerve, the axillary nerve. All these nerves will be coming out of the brachial plexus. So in this, what you have to importantly remember is this point where is the junction of C5 and C6. This is called as Erb's point. Any injury to the Erb's point leads to Erb's paralysis or Erb's palsy. Okay. So how the injury happens? Usually the traction and rotation of the head during the vertex presentation to deliver the shoulder tends to injure C5 and C6 nerve roots, and associated damage to the phrenic nerve at C4 is less common, but if it happens, it will cause ipsilateral hemiparesis of the diaphragm and congenital anomalies such as cervical rib, abnormal thoracic vertebrae, or shortened scalenii anticus muscle can cause pressure on the lower plexus. So what here we are discussing is if there is upper plexus involvement, maybe because of the delivery, and lower plexus involvement may be due to anomalies like cervical rib or abnormal thoracic vertebrae or shortened scalenus anticus muscle, they all lead to injury of the plexus. Damage can occur at the level of nerve roots attached to the spinal cord, or at the anterior or posterior rootlets, or distal to the where the rootlets coalesce to form the mixed nerve roots that exits the vertebral canal. So it can happen as soon as, like for example, let me draw. See, this is the spinal cord, and the nerve root will be coming out to the spinal cord. So this can happen immediate injury to the attachment to the spinal cord. Directly it can get avulsed from the spinal cord, or after that it will be divided into roots. Okay, so it can happen at the root level, it can happen at the connection level, or it can happen at the division level. So at any level the injury can happen into the spinal cord. So the amount of damage, how it happens, depend upon that is again classified into complete rupture, that is neurotemesis. There will be two parts after the injury. Axonotemesis, the axons inside the neural sheath will the disruption of the axons, but the covering will be there. So for example, if it is complete cut, then there is two parts. Okay, this is neurotemesis. Axonotemesis, there is a covering sheath and there is axon inside. So the axon is cut, but the neural sheath is remaining intact. That is axonotemesis. The neuropraxia is there is a kink or compression. Okay, so there is a compression on the nerve due to some external force, and when you release the compression, there is no cut actually. So it's a temporary nerve conduction block. So this is the three varieties. Either it can be neurotemesis or axonotemesis, or it can be a neuropraxia. Neuropraxia usually recovers very well. Axonotemesis, there are good chances of recovery, but neurotemesis requires a surgery for improvements. So whenever there is an injury, whenever it is Erb's palsy, the injury can occur at any level of the brachial plexus. But the most common injury is the upper root, the joining between C5, C6 level, that results in Erb's palsy. And sometimes C5 to C7 can also be involved as a result of injury to the fibers from upper roots. The child's shoulder is usually like this. It is in extension, internal rotation, and adduction. Elbow is extended, forearm is pronated, and wrist and fingers are flexed. It's like a waiter's tip position. So if the waiter want to take some money from without showing it to anybody, so they may take like this. That's why it is called as waiter's tip position. Paralysis of the rhomboids, levator scapulae, serratus anterior, subscapularis, deltoid, supraspinatus, infraspinatus, supinatus, and long extensors of the wrist, fingers, and thumb can be expected. So all these muscles will be paralyzed. Only grasp will be remaining. Elbow and finger extension is compromised if C7 also is involved. Erb's Klumpke's paralysis is a combination of the total injury, involvement of upper and lower roots, everything will be involved. This is resulting in total arm paralysis and loss of sensation. The extent of the initial paralysis frequently recedes with the total paralysis and becoming limited to the muscles innervated by the upper roots. So usually whole C5, C6, C7, C8, T1 all are involved in the complete paralysis. The whole upper limb will be flaccid. The sensations of the upper limb also completely lost. And whenever there is involvement of T1 nerve root, it leads to a syndrome called Horner's syndrome. Usually, if you see this eyes, you see this is normal and this is abnormal. So usually it is because of the result of avulsion of T1 nerve root, which can cause efficient sweating. The eyeball will be retracted behind. The pupillary contraction. See, you can see this is the black pupil. Here it is big. And pupillary contraction state. The meiosis. Okay. Contraction of the meiosis. Ptosis, the half of the eyelid is closed. And iris will become slowly into different color. So this is called Horner's syndrome. Sometimes the Klumpke's, it involves only the lower roots C7 to T1. The shoulder and elbow movements are not impaired, but resulting position of the forearm is typically in supination. And there is paralysis of the wrist flexors and extensor muscles. and the intrinsic muscles of the wrist and hand. So that will be the Klumpke's paralysis. The contracture most likely to develop in the scapular protraction, shoulder extension, adductions, internal rotation, elbow flexion or extension, forearm pronation, and distant finger flexors. These will become contracted. So because of the involvement of the muscles, there will be activity limitations. This will vary depending upon the initial pathology. Like for example, if you have complete cut, you may have complete activity limitation of the upper extremity. If you have partial cut, then you may have partial limitation. Neuropraxia, there may be no limitation. So this will be varying depending upon the initial pathology. The neurological regeneration, residual impairments can also have actions. The inability to reach, grasp, perform tasks requiring bilateral manual abilities such as catching a large ball or lifting the large objects, all this may be affected. ADLs also may be compromised, especially donning and doffing of the cloths requires bimanual control, two hands control together. So those things will be affected. Wherever one upper extremity can be able to do the activity, the child will be able to do without any problem. The physical therapy examination, mainly active and passive range of motions and sensory status is the key in establishing baseline of the function and abilities. MRI, CT scan, electromyography can be done to diagnose the level of injury. Range of motion is performed in all the movements with greater care because the joints may be unstable and the limbs may have sensory loss, so you cannot roughly move into all the direction the upper extremity. Based on the functional problems of the shoulder, it is described in Mallet's grading system for shoulder function. So usually one is complete paralysis, the 5 is normal shoulder. In between 3 are described like level 2, level 3, level 4, level 2. This is level 2. You can see this picture. So the active abduction is possible for this greater than 30 degrees. External rotation is 0. There is no external rotation. Hand to the back of the neck is impossible. So the child cannot put the hand behind the neck. Hand to the back also is impossible. But hand to the mouth gives a trumpet sign. The elbow goes up when you want to put hand to the mouth. That will be gradually decreasing in grade 3 and grade 4. Once you check the range of motion and sensation and function, then it is very important muscle strength. In the infants, the physical therapist can observe the limb movements or palpate the muscle contractions while testing a variety of reactions and reflexes like visual tracking, neck writing, Morose reflex, Gallen's reflex, hands placing reaction, and care if movements are within the normal gravity. So the other hospital people, you have to collect the muscle strength factors and muscle strength related information. Rather than using our traditional MMT, in pediatrics, you can use this active movement scale for children who are younger than 1 year to mark the muscle actions. And even sensations also graded. Attempts should be made, however, to identify areas on the involvement of activity that may compromise sensations, like no sensation, no reaction to painful or other stimuli is S0, and S1 is reaction to painful stimuli but not to the touch. S2 is reacting to the touch but not to the light touch. S3 is normally reacting to all the kind of stimuli. The physical therapy goal during the first few months after the diagnosis is to support a spontaneous recovery that is occurring and prevent any movements of the upper extremity and prevent secondary impairments of the muscle contractures and joint injuries. A first immediately a resting period of 7 to 10 days post-injury will be given. This is required to allow the reduction of hemorrhage, edema around the traumatized nerves, because if they are becoming more, they itself can cause the secondary damage to the nervous system, the swelling and edema and hemorrhage. So this time no range of motion or other interventions are initiated, as the involved limb is positioned gently across the abdomen like this. Then living on the involved limb is to be avoided. The passive range of motion can be done in context of normal developmental activities as described previously, or during the positioning. It should be never cause pain, and the movement should be always gentle. Overstretching can be harmful. The joints and joints capsule that are usually unstable in these kind of children. The prevention of scapulohumeral adhesion is an important goal of physical therapy interventions. During reach, the scapula can be stabilized. So in the reach, usually, shoulder glenohumeral rhythm. The initial degrees of movement is majorly done by the humerus alone on the scapula. Later on, the scapula moves more than the humerus to complete the full range of flexion and abduction. But in these children, the beginning range itself, the humerus will be moving along with the scapula. So to prevent that movement, the scapula is holded, and they will train the movement of only humerus. Beyond 30 degrees, the scapula must be rotate along with the humeral external rotation to avoid harmful impingement of shoulder on the acromion process. So even positioning of the child, if the child is keeping the arm in weighted stiff position or arm in abnormal position, that will cause contractures in that abnormal position. So to prevent that, you have to keep the upper extremity in aeroplane splint or any other splint which is affecting the upper extremity function. Like placing the child's arm optimal position is a time efficient way to stretch the soft tissue restrictions. Because of this can be done during feeding, carrying and positioning in a car seat. When the child is sleeping, the arm can be placed towards the abduction, external rotation, elbow flexion and forearm supination on a pillow to the child's side. As the child arm relaxes during the sleep, even more range you can attempt. So, or you can use an airplane splint to maintain the hand in a good position. One of the best physical therapy treatments which are till now portrayed for damage to the brachial plexus is constraint induced movement therapy. A restraining splint such as air splint can be used on the uninvolved extremity to encourage the use of involved extremity and hand. So this can be done, and this can be used as a treatment strategy. So the electrical stimulation. It was recently reported that electrical stimulation paired with conventional physical therapy resulted in improving active shoulder abduction, elbow flexion when compared with conventional physical therapy after 6 weeks. So that means if you do 6 weeks of electrical stimulation, you can strengthen the muscles. The recovery will be better than without using electrical stimulation. So this electrical stimulation is majorly for strengthening the muscles around the upper extremity who are involved by the brachial plexus injury. So that's it. This is all about a brachial plexus injury. So in summary, the brachial plexus injury is involvement of the whole brachial plexus or part of the brachial plexus. If the part of the brachial plexus involved, it is called as either Erb's palsy or Klumpke's palsy. The Erb's palsy is involved, the whole upper extremity will be involved except the hand muscles. In Klumpke's paralysis, hand muscles are more involved, then other part of the upper extremity is less involved. In whichever the type of injury, the brachial plexus, if it is complete injury, the recovery is very poor. It is incomplete, recovery is incomplete, or partial injury, the recovery is very good. And physical therapy plays a very important role in improving the child's functional capacity by using various techniques like exercises, range of motion techniques, increasing the strength in the muscles, weight bearings, weight shifting, electrical stimulation, therapeutic exercises. All these things can be done to improve the upper extremity function. So this is all about brachial plexus injury. Any doubts, you can contact me through the post message.